Well, good morning, everyone. We'll be doing another rendition of neuropathology. I believe Dr. Goltekin is here with us today, so he'll be teaching us as well. I don't have any juniors that are on right now. But we can proceed, and then hopefully someone jumps on. Well, I'm happy to ask myself the questions.
Doesn't matter. You can pick on the faculty, man.
Oh,
They
that
may not.
sounds like.
They may be sleeping.
Oh wow, my that would be an interesting neuropath. Well, we can start with just an interesting case. So a lot of these cases are being sourced from University of Miami Hospital from the last few months. First case is that of a 67-year-old gentleman who initially presented with eye pain and headache 7 years ago. He underwent a craniotomy for a tumor resection, but unfortunately couldn't really tell us what the tumor pathology was at the time. It wasn't done in the United States. And so he's now presenting with some cranial neuropathies, diplopia, right itosis, worsening headache. His only real significant past medical history is that he had a brain tumor that was resected, and he had radiation there and some GERD. Let's see if anyone is on target. Not yet. Okay. So the exam, you can see he's awake alert oriented. He has that right ptosis. Right pupil is minimally reactive. Right eye decreased adduction. So he has some ophthalmoplegia. He has a tongue deviation to the right, lower cranial neuropathy, and he has symmetric strength. So he has some cranial neuropathies and headache and a history of tumor in the past that we know was radiated, was at least partially resected, but we don't have the pathology from. When we're looking at the imaging, this is a contrasted scan. You can see multiple cuts through the skull base. You can see this contrast enhancing, relatively homogeneously contrast enhancing lesion that seems to be originating from somewhat of this like middle skull base region where the clivus would be that extends right more than left into that cavernous sinus. You can see in multiple cuts. You can also see a little bit of that encroachment into the temporal pole as well as that edema as well in this scan. So makes sense as to the cranial neuropathies this patient is experiencing, particularly in that right-sided. And then, Vaidya is on. Okay, Vaidya as the first junior on. Can you tell me if it makes sense as to why this patient is having cranial neuropathies given this patient's tumor location?
Sorry, just got on.
Yeah, so just really briefly, this 67-year-old man had a tumor resected 7 years ago now outside in a foreign country. We don't have the pathology, but he's coming back with this exam. Pardon. Basically, awake, alert, right ptosis, pupils minimally reactive, right eye decreased adduction, tongue deviation to the right, symmetric strength, and he has this lesion in what appears to be the clival region, skull base, eccentric to the right side, that extends into the anterior temporal pole region and mainly that cavernous sinus on the right side.
Oh, okay, sure.
And so the question is, yeah, he has cranial neuropathies, right more than left, and they seem to be those with the nerves to the optic apparatus, really the motion of the eyes, some lower cranial neuropathies like the tongue deviation towards the right. Does that make sense with the location of this?
Yes. So given that it looks like it's extending into the cavernous sinus, you would expect some oculomotor neuropathies associated with that. And if he's having tongue deviation, that would point towards him having some involvement potentially in the brainstem as well. I think it's tracking all the way up the clivus. That would make sense.
Perfect. And because you've done a great job. What are the cranial nerves that will pass through, or at least in the dural leaflets of the cavernous sinus? An extra point if you can get the one that's in the cavernous sinus directly.
Yeah, you'll affect 3, 4, 6, I think you may affect some branches of 5 as well, but I forgot exactly which ones.
No, it's perfect. Yeah, so you're right. So 3, 4, V1, V2, and then the one that's in the cavernous sinus directly, not in the dural leaflets per se, would be
Uh, I'm sorry?
would be 6.
Okay.
Perfect. So very good, very good. These are just some more cuts of the same tumor. You can see contrast enhancement heterogeneously into that anterior pole of the right temporal lobe. It looks intra or extra axial to you.
This looks, let's see here. It looks extra axial potentially.
Perfect. Yeah, perfect. You have some edema on the T2 here. You can also see in T1 that it's relatively hypo intense in comparison to the surrounding brain parenchyma, and flare signal is increased on the temporal lobe, which we are aware of. So he has headaches, he has neuropathies, etc. He has a history of a tumor in this general location that was operated on once and radiated. So what are you thinking in terms of your differential? Like, what could this possibly be? Midline structure, history of radiation.
Yeah, so given that he has this extra axial lesion, first thing that comes to mind is possibly a meningioma, but a lot of the radiographic features don't necessarily correlate with that. He has this clival-based lesion that was previously radiated. I think you can also consider a chondrosarcoma at that point. Um, I don't know what else I would potentially add onto that. A Met would be pretty rare. To be in that location and extra axial on top of that. Um, I don't
Very
remember
good. Yeah,
necessarily
very good.
anything else.
Well, there's one more thing that's kind of midline that would essentially involve the clivus, involve the skull base that you should always have on your differential. Granted, it's a little bit atypical for it to go, AC-centric to the right or left, but it theoretically could if it gets large enough.
A chordoma.
Perfect. Exactly. So you hit it on. So one of my colleagues told me I'm muted. Thank you. You're very right, Badia. So chondrosarcoma, chordoma, Met, meningioma, like you said, plasmacytoma could very well be sequelae of multiple myeloma. So these are just small things. So again, craniopharyngioma, nasopharyngeal carcinoma, unlikely, but possible if you want just to fill out your different.
Okay.
So the plan, and we can kind of bump this up a bit too now if you would like. Tyler, are you on?
Yeah, I'm here.
Perfect. So what do you think we should do for this guy?
Um, we should take it out.
I
We
love
can
it.
do, yeah. Sorry, can you go back to the imagery again, real quick,
Absolutely.
sir?
These are the coronals.
Okay. Yeah. So, given that it is, it looks like it'd be pretty difficult to reach endonasally.
Mhm.
So I'd probably do like a right crani, either maybe like a terional, although it's pretty anterior. I don't know. I don't know if you'd have to do something larger like an OZ.
Awesome. Yeah, exactly right. So you have a bulk of this lesion that's coming more eccentric to the right along that sphenoid wing. You're right. It would require an expanded endonasal to get as far out to the right as possible to do that. You can get the midline stuff, but you'd have to look down to get that clival extension. So the plan was to try to remove this large bulk that was adherent to and along the cavernous sinus wall. And so as a result, the plan, like you had astutely mentioned, was going to be a right OZ. Very good. So then they get in there, they take some tissues, and this is what we find. Dr. Gultekin, if you're available.
Yes. So as you mentioned, this is a chondroid tumor. You can see from the matrix, the background, that there's this myxoid material, and there's a sprinkling of cells that don't look so atypical. They have round to oval nuclei and elongated, very sort of stubby processes. And overall, it's mild to moderately cellular. And this will be important for grading. I don't see any mitotic figures. I don't see very extreme nuclear atypia. So I would think of a chondrosarcoma, and there are these like occasional examples of double nuclei on the right upper quadrant. There's a cell with a two nuclei essentially. Is there any other picture? Yeah, so high power shows the similar characteristics in that individual nuclei are mildly atypical. You know, there's a moderate amount of cytoplasm. The background is the same. So we're going towards a grade 2, like a moderate grade chondrosarcoma here, lack of obvious atypia and mitosis. Next. So S100 is a good marker for chondrocytes and chondrosarcoma. As you can see here, it labels both the nuclei and the cytoplasm of these individual tumor cells unequivocally, and so that supports the chondroid differentiation. Now, brachyury is a marker. It's an embryonal transcription factor that is overexpressed in chordoma on the right side. You can see a chordoma case, a very different morphology from what you see on the left. Chordoma has these bubbly cytoplasm, phycilliferous cells, so-called phycilliferous cells, and round nuclei, and these clusters and cords of cells within a myxoid matrix, or, you know, as opposed to chondrosarcoma, which has a completely different morphology on the left side, more elongated cells, and definitely does not have the bubbly appearance of individual cells, where you see that bubbly phycilliferous appearance on the upper half, especially onto the right side. Exactly. Yeah. So brachyury is a specific marker for chordoma, and it revolutionized the specific diagnosis of chordoma. What you're showing me here is some very heavy background staining or cytoplasmic staining, especially of the chondrosarcoma cells. I find this a little odd and difficult to interpret, because in my practice and in the literature, chordoma distinctly stains with brachyury specifically, and the imitators of this situation is really not there. So it's difficult to interpret this background staining, probably a trick of the immunohistochemical labeling at that time. That wasn't my case, so I don't remember it very well. Okay. So the diagnosis is chondrosarcoma with all the morphological attributes and S100 positivity. It's a grade 2 out of 3 because of, again, lack of high cellularity and distinct nuclear atypia and mitotic figures. Thank you.
Thank you, Dr. Golteka. Yeah, so exactly. So chondrosarcoma. And so just really quickly, the most important things to notice about chondrosarcoma is cranial neuropathy is most common, right, given their generalized location. And calcifications in these lesions are normal, though in this situation, I didn't give you a CT scan. I believe there were some calcifications in that lesion and in that region lesion. Most common location, petro-occipital synchondrosis. So essentially, this is critical as to why these would be off midline, right? If you're going to have a chondrosarcoma, they're going to come and arise from the synchondroses of the skull. And so that's why you have it on right versus left, but not necessarily always midline. This is what differentiates it from that chordoma. And so Vaidya, if you're still on, where do chondromas come from? Or sorry, chordomas, excuse me. Chordomas come from.
I'm actually not sure the cellular origin of chordomas. I think they might come from like developmental tissue.
Exactly. So
Notochord possibly.
Cord, oma.
So like the notochord.
Perfect. Very good. And so exactly. So right, if the notochord is a midline structure, and that's going to give a rise to multiple kind of spinal structures, for example, most specifically the nucleus pulposus of the spine, you're going to have it in the midline, right? So very good. And then these are just the enhancing characteristics of them on the imaging characteristics below. Histopathology, we already went over some of these things. S1 positivity, and like Dr. Gultekin said, higher grade chondrosarcomas will show higher cellularity. These are the general surgical pearls. We can see the 5-year survival, grade 1, 2, 3. And radiation surgery are the standard of care. So it made sense. Wherever he got the surgery done first, they didn't do a bad job. Very good. So next case, we'll go with, let's see, is anyone else? Don't see. You want to take this one again, Vaidya? Immediately start the first half, and then you're doing such a good job.
It's fine.
53-year-old male presenting with 6 months of diplopia, dizziness, gait, and balance. Exam intact, past medical history, none. Not very specific. We're going to get some imaging. So this is what you're finding. A little tricky, right? You have this contrast enhancement, but then also this flare intensity. What can you make of it? What can you make of this? Where is it? Just describe it.
Yeah, so as this, he has this enhancing lesion in the left cerebellar peduncle. It's also hyper intense on the flare imaging. Looks like there may also be some nodular enhancement as well. In terms of a differential, I mean, it would be hard to nail down without like a biopsy or anything, but you could consider maybe like a glioma. A MET would be pretty rare in this situation. It doesn't necessarily look extraaxial, so I wouldn't 100% consider a meningioma at this point. Looks like it's an intraaxial lesion. I think that would be the basis of my differential right there. I mean, other cerebellar lesions be pretty rare, especially how old is this guy?
53.
Yeah, 53. So, I mean, I wouldn't necessarily consider like the juvenile posterior fossa tumors all that much either.
Yeah, and you're right, right? Something to also kind of watch, keep in mind, right, is that inferior cerebellar peduncle. It looks like the flare intensity of the actual lesion extends beyond just this enhancement right there. And so the differential, like you mentioned, are going to be intraaxial and intraaxial tumors more likely because of that flare intensity that you're seeing here, right? So gliomas can do something like this, right? Low-grade gliomas, but we know that with a nodular enhancement of any of these types of tumors, that's more likely to be a higher grade lesion than not. But again, hit on the head, right? So differential included astro, met, lymphoma, hemangioblastoma, and Lermite du Clos. We can go over Lermite du Clos, but if you would like to do that, we can move on. We'll move on. Adam, if you are available.
Yep, I'm here.
Perfect. All right. What would you do? You're UMH neuro. You're UMH. You've been assigned this case.
Yeah,
You don't
sure.
have a plan. What do you do?
For this patient history, did he have any primary cancer or anything? Because you were mentioning Metson, so I'm
Yeah, no primary cancer at all.
no
The guy
primary.
just comes in with a little bit of diplopia and some like non-specific, some like headaches, those kind of things.
So not
All that stuff.
nothing symptomatic on here. Okay. So I would still go for resection. So I would plan for a retrosigmoid approach on this patient. Can I?
Yeah, not exactly, not a bad option at all, right? And so the plan was at that point, again, you can kind of slide into this space here to try to resect a lot of that mass. Now, granted, a lot of this stuff is extending. You can see this flare intensity is extending further back, right? So resecting through a retrosig might be a little bit trickier, just to try to get that angle into this lesion, unless you'd want to take a majority of this portion of cerebellum as well. So the plan was similar to retrosig, but they decided suboccipital craniotomy for this one, which again, reasonable to do, right? So after that, what was the path? So intraoperatively, path was set, and this is what we're finding.
So this lesion looks like a primary tumor. First of all, it's not a metastasis. It's a primary neoplastic proliferation of the CNS. It has fibrillary background, almost neuropill-like areas, and small, not so atypical cells, more cellular to the right side here. I don't see any vascular proliferation or necrosis. Mitotic figures are difficult to discern at this power. So go to the next, please. Yeah. So again, you see here, there are some capillaries. I was wondering if this one or two areas on the right half were Rosenthal fibers at all. That could be. There's some nuclear atypia on the same area, like enlargement of the nuclei becoming darker, more atypical. And you can see in this power the distinct fibrillary background, which are the processes of the cells that constitute the tumor. Once again, at the very top right, you can see big enlarged tumor cell nuclei that is at considerable atypia. No mitosis again. There are these, in the center, there's this acellular area. I don't see a rosette, but it is reminiscent of the anuclear zones that you see in neurocytomas, but this is not a neurocytoma. It's an odd structure. Next. So again, vasculature is delicate. No discernible increase in mitotic figures. Overall, histologically, this looks deceptively low grade, low to intermediate grade, maybe. But it's going to turn out to be okay. Also, Ki67 index is probably no more than 5%, more or less here. So it's low. GFAP shows on the left side that this is a astrocytic or a glial tumor. Individuals cells, their cytoplasm labeled with GFAP, as well as the nuclear marker of glial differentiation, OLIC2, is positive in all cells except the endothelial cells. Next. So unfortunately, this H3K27M mutation-specific marker, immunohistochemical marker, is positive in each and every single tumor cell here. So again, this is a immunohistochemical marker for a mutant version of this protein. So when it's positive, it means there is mutation in this histone acetylation element. And that means diffuse midline glioma. And yeah, WHO grade 4, which is really an ominous prognostication. So it's interesting to see it doesn't look like a glioblastoma, right? Doesn't have super high atypia, extreme cellularity, mitotic figures, necrosis, vascular, the usual attributes of a higher grade lesion in the CNS. Yet it does have this histone acetylation element mutation. So specific the H3K27M, and that makes it a diffuse midline glioma as per the latest WHO classification. That's it.
Thank you, Dr. Goltekin. Yeah, no, I thought it was very interesting. Right, the whole scenario seemed to be pointing towards something lower grade with maybe aggressiveness with that contrast enhancement. But then you see this as the final pathology, and just interesting how the tumors themselves may not necessarily look very aggressive from the generic markers and so we use, but then when you utilize this specific marker, it turns out fortunately it's a very, very aggressive lesion. So okay. H3K27 altered diffuse midline glioma. So this is more oftenly common in children, presents with cranial neuropathies or cerebellar signs, and these are the markers that are generally positive: S100, OLIG2, and then H3K27 mutant positivity. So low-grade appearance on histology, glial hypercellularity with some atypia and pleomorphism, and hypo intent on T1 minimal enhancement, all of which we were seeing. They removed DIPG in 2021 as a nomenclature and instead classifying these as H3K27 altered diffuse midline glioma. Molecular feature is more important than histology. So takeaways: midline glioma or midline structure glioma. Just kind of keep this back in the back of mind in terms of differential as well when you're resecting these. Here are the general survivals. 2 years, less than 10%. Very good. Alrighty. The next one, let's see, is Aman on? Aman is on.
Yeah, I'm on.
Perfect. All right, my friend. Your next, your
All
case, 67 or 64, female, headache, lancinating left facial pain. Past medical history, high diabetes, hypertension, hyperlipidemia, and a history of uterine cancer. Exam, however, is intact.
Okay.
Left facial pain. What are you thinking about in terms of lesions in the skull that would potentially presenting as headache and pain of the left face?
Yeah, it's lancinating pain. It sounds like obviously trigeminal distribution. I would want to know that on exam. Are we getting? I mean, is it the complete hemiface? Are we getting? I want that. I guess part of the history.
Yeah,
So I'm thinking of any. Yeah.
Side. And so the exactly trigeminal nerve, right, is what you're going to be generally focusing on, at least preliminarily. And so what are the divisions of the trigeminal nerve, not just V1, 2, 3? What are their names and where do they go? What are they rather? What foramen do they exit from?
So we have the foramen ovale. We'll have V3 coming off of there. Mandibular branch. We'll have V2 coming out of rotundum. And then V1 is just going to be coming out of our superior orbital.
Good. You said mandibular or for V2 or? maxillary for V2.
V2 is maxillary.
Perfect. Very good. Very perfect. Perfect. Exactly. So you're thinking potentially something in the left skull base. If we now, with your context clues of this being a neuropath, this is probably a cranial tumor, probably somewhere in that general region.
Yeah, I think that's fair.
But let's hypothetically say you did not know any of that and you got this. What are you looking at?
So we have at the top we have axial MRIs. We have our T1. We have a flare. Sorry, we have a T2
yeah.
and a flare. Yeah.
So
And then
T1,
yeah.
flare, T2. What is this guy right here? What sequences? So you're right, exactly right. So
diffusion restrict. That's DWI.
Perfect. Perfect.
Yeah.
Yeah. What are you seeing?
So looking through my images, I do see a lesion in the left temporal lobe. It's on T1 hypo intense, and then on T2 it is hyper intense, and then on flare as well I see a hyper intense lesion.
Perfect.
Well,
what would you say hyperintensity for diffusion, or would you say diffusion?
Oh yeah, right. So for diffusion, it's restricted.
Perfect. And then show me that, like, just to top us all off, this final image on the bottom.
The post.
Yeah.
And that we have some enhancement on the rim. Yeah.
Perfect. And so, if I were to ask you, right, I actually we'll get there, right? So what is looking at something like this? What is your differential? Right. So you have a lesion, anterior temporal pole, diffusion restricting, kind of contrast enhancing, at least in the periphery.
Yeah. So when you're talking about diffusion restriction, I mean, in something like this, it could be an abscess. That's been a differential. It could be a lymphoma. It could be diffusion restriction. We can see on epidermoids, dermoids. In this case, with diffusion restriction, I don't know if meningioma would be on our differential still, but I think we should consider something like that.
You already hit the head, hit the nail on the head with but it's probably going to be, right? But now just to, you're completing out the differential. I love that. I love that. So exactly, right? This general location is going to have all these potential lesions, but at the end of the day, you have a structural pathology causing a symptom that you can correlate to that structural pathology. So you're right. So epidermoid, arachnoid, met, lymphoma, abscess, very, very good, right? Is it likely an abscess? Probably not, right? She looks pretty good. She's seeing it in clinic. Is it a lymphoma? Very well could be, right? No other history of lymphoma, but could it be a met? Very much so, right? She has a history of uterine cancer, so perfect, very well.
Oh yeah.
What do you want to do about it?
So she's coming in, and right now her symptoms are just the facial pain. That's all we have.
I want to end it all. This pain is horrendous. I cannot live like this anymore.
Yeah, I mean, if her pain is she's and it's like that bad, we would consider resection and sending off her path. And I'm assuming I'll say she's failed all other conservative treatments and for her pain, and I take a resection. I do a left temporal crani probably and take it out.
That is exactly what happened. Very good, very good. So for the neuropath of what you resected, and by the way, her pain is completely gone because of your gifted hands, Dr. Samal. So good job.
So, interesting discussion. You can see here immediately in the upper part of the center, a squamous lining and some flaky keratin debris flying off that base into the lumen. So we're talking about, one of those cystic benign lesions, and then the pink area at the bottom is all connective tissue, etc. So from right off the bat, this looks like an epidermoid cyst because of the squamous epithelium, the dry keratin in the lumen, and I don't immediately see any adnexal structures. If I see them, then I call it dermoid cyst instead of epidermoid. Next. So similar attributes here. You can distinctly see the basal layer of the squamous epithelium here. Again, epidermoid is like skin-like, and then you can see the keratinization at the top, which again sloughs into the lumen of this structure, cystic structure. And then the variants of all that architecture, just, with winding and making nooks and corners here and there, depending on the cut of the histological section. So it is an epidermoid cyst. Next. Well, here you see a reactive environment where there is fibrosis, hemosiderin, a lot of macrophages and plasma cells and mature T cells probably. So and then cholesterol clefts, these big elongated white optically clear areas. I would think that this would be either the contents, or if it's ruptured into the adjacent tissue, then you would see this kind of reactivity too. We see this with Rathke's cleft cyst also in the correct location, as well as ruptured epidermoid cysts, ruptured, in areas of pilonidal sinus in the spinal area, etc. So it's a common phenomenon when a benign cyst with keratin contents ruptures into the surrounding tissues. Okay, that's it.
Very good. Perfect, thank you. So exactly, so epidermoid cyst, slow linear growth, often presents with cranial nerve deficits from mass effect, CP angle, most common location. And on DWI, it's going to it's going to restrict. Excuse me. So this can cause aseptic meningitis, right? What is the name for this, Aman? Right, a aseptic meningitis in a patient with epidermoid cyst. There is a specific name. It's like an eponym for it.
Molaires?
Exactly. Well, yes, exactly. So Mollaret. I took French in high school. It's been a while, but exactly right. So that aseptic meningitis is that consistent aseptic meningitis in a patient with epidermoid. It's like buzzwords that go together. Exactly that when these things rupture, they can in turn irritate the meninges, causing that aseptic meningitis. And when you look at them intraoperatively, they have really, really like interesting curly white appearance. So that's also that squamous epithelium, keratin, and cholesterol crystals all congeal together to form this pearl, basically. Treatment surgical, rate of recurrence inversely correlated with extent of resection. So if you only get 50%, or rather, so if you subtotally resect it, you're going to likely 50% of the time go back and get it again. 0% after gross total or near total resection. Very good. So this is the last case. Seth, are you available?
Yeah, I'm here.
Perfect. Very good. Very good. So,
All right.
Go for it.
77-year-old male. He has 1 month of numbness in the bilateral feet, ascending up his legs. He also has gait imbalance and intermittent urine leakage. He's got a history of diabetes, aortic valve replacement on Eliquis. And then on exam, he's 5 out of 5 strength throughout, decreased sensation to touch in his legs, decreased reflexes bilaterally in his legs, and normal proprioception.
Perfect. So,
yeah, so
do you
I
have
probably
yes?
I want to ask about, huh?
Yeah, sorry. Question. Ask away.
Yeah, so just asking about more about his bowel bladder incontinence. How long has that been going on? Does he have any like history of prostate issues or urinary issues in general? And any like back pain? And in terms of his like numbness in his feet, whether that's like diabetes, peripheral neuropathy, whatever.
Perfect. Yeah, no like significant neuropathies from his diabetes is well controlled. That 1 month of numbness in the feet ascending to his legs, also kind of correlating around the time they began to quote more leak urine, but he's always had a little bit of urinary latency. He has some prostate enlargement, but these are all very new symptoms for him that have occurred over the last few months. And
Okay,
so,
yeah, and then I know we have an exam, probably get like a rectal tone and maybe a PVR, but otherwise, like let's look at I think a CT and MRI.
perfect. So this is what you find, right? You have essentially, before you even go there, right? You have weirdly, right, an lower motor neuron reflex, which is the diminished reflex, normal proprioception. This is one of those things where, well, you would probably think something lower motor neuron issue with those things, right? But then when you look at imaging, where are you looking at? Where are we finding this?
Looks like there's a lesion upper thoracic, like spanning T1 to T3 or T1 to T4.
And so this is your T2, T1 in contrast. Describe it in those terms.
Oh yeah. So it's a T1 hypointense, and then on the T2 and flare, it's hyper intense. It looks
T2 and then contrast, right?
Yeah, and then on the axials, it looks intradural, intramedullary, I think.
Perfect. So what are the categories? And now that you've given the buzzword, what are the three? So it could be intradural, intramedullary. It could be
intradural, extramedullary, and extradural.
Perfect. So that will guide your differential.
Yeah. So just like thinking about the cells in the core, we can have an astrocytoma, ependymoma. And then
those are generally going to be the two very most common. But just to complete out the whole possible differential, right? What are other things?
Maybe like meth, or like maybe lymphoma.
Yeah, lymphoma can basically do anything, right? So exactly, right? There's a whole host of things. Don't ever forget, I mean, demyelinating inflammatory is a possibility, right? Because this gentleman, ascending symptoms. Granted, you would also likely have some sort of a history of like neurological issues that resolve or get better and then come back and then get better and come back. History of MS, those kind of things. But exactly, the top three are going to be your astros, your ependymomas, your lymphomas. And of those, astro and ependymoma are the most common, right? But this guy has symptoms. He also needs diagnosis. What are you going to do for him?
Yeah, I think you should probably consider resection. I think a posterior approach, laminectomy, and resection.
Mhm.
I think, yeah, we'd need like patient would be prone, use ultrasound to localize the lesion, I think.
Perfect. Mhm. Exactly. Right.
and-
Well, on ultrasound, what would you see? Right. You do your midline laminectomy. You haven't opened dura yet. You call for the ultrasound. You flood the field irrigation, and you put the ultrasound in. What would you see on ultrasound? I mean, not a trick question per se, but what would you see, and where would you want to make your durotomy?
I think I'm not sure.
Well, if you have an intradural intramedullary lesion, right, in comparison to normal spinal cord, what would that segment probably look like?
Yeah, I think it would have it'd be like expanded there. I think there would be probably some like density difference between that and the cord.
Yeah, very good. And
And
so
so we
that
can
midline
move it. Yeah.
Yeah, that durotomy you're gonna make, right? How would you know where to start and finish that durotomy?
Probably maybe extend it a little bit above and below.
Exactly. So, right, you'd use the ultrasound to look at normal spinal cord above,
Yeah.
normal spinal cord below, and that's where you're basically be targeting your durotomy. Very good.
Yeah.
So, like you said, laminectomy for biopsy is what was planned, right? Because at the end of the day, right, you have intradural intramedullary lesion. You don't necessarily know what it is. It doesn't have the very classical characteristics of like an ependymoma or an astro per se. But then again, right, there are targeted therapies for a lot of these things now, particularly astrocytomas. And we can talk about that later, but the baseline, you at least want to understand what this is. And his symptoms they're not great, but at the same time, he's 5 out of 5 strength. So you have a lot to lose for this guy. And so biopsying to understand what it is what was planned for this gentleman. And again, as much to be removed as possible, but this was the plan. So the neuropath.
Okay. So this would be a difficult frozen if it was sent to frozen. You can see here in a eosinophilic background individual cells that are separated from each other. They don't seem to align or oppose to each other. There's some pleomorphism in that the nuclear shape and size are different. It's really difficult to say much on the H&E stain here. There's some artifact on the right side smearing out. This happens in lymphomas. So, a possibility is a lymphoproliferative disease here. Next. Another suboptimal picture here, but now you can see better the round, small cells that don't have visible cytoplasm or are very minimal, and this supports the lymphoproliferative suspicion that I had in the previous slide. Next. So now you can see that the CD20, which is a B cell marker, is diffusely positive in these cells. So that, is unusual in an inflammatory environment because inflammatory cells are typically T cells and macrophages. We're looking at here a diffuse B cell infiltration. So that definitely is speaking for lymphoma or an atypical lymphoid infiltrate, which may turn out to be lymphoma by molecular means. Next. PAX5 is a general marker, transcription factor for lymphoproliferative I'm sorry, lymphoid cells, and this is positive, and that removes any doubt that these are lymphoid cells and any, artifacts of immunostaining, etc. So we're looking at an atypical lymphoid infiltrate. Anything else there? Yeah, so the reason why this was a hesitant diagnosis is that I don't know why, but the tissue is not really high quality. Something happened to the tissue somewhere between the OR and the pathology department, and maybe it wasn't fixed well. Maybe it was kept unfixed for a while. Who knows? And anyway, I don't know if this must have been sent for molecular analysis later on to definitely define the lymphoma. Do you know, Samad?
So I'm so sorry, Dr. Goltek, you cut off a second. What did the question was?
The question was, did you see a next generation sequencing or any other molecular assays?
I didn't when I looked at this case. I can go back.
That's
I didn't
okay,
see
but I'm
anything.
saying this is not going to be enough for
Mhm.
the hematologist or oncologist. They would want to say, how do we make sure that this is not just suspicious, but definitive, right? So that would require PCR or other molecular means, sequencing, etc. We typically give it to the hematopathology, division to elaborate on this, and it's out of my hands at this point. But I was just wondering what it's a monoclonal B cell population, of course, because there were, there was a marker CD20 which we showed. I'm answering to a chat message. Yeah. So anyhow, it's a lymphoma.
Okay. And then I don't.
Dr. Shah is asking about CSF studies.
I don't recall if CSF studies were done after the fact. I think after the biopsy was completed. I can go back and confirm that. I have the MRN. I didn't specifically look for that though when putting the case together. I can find that out for you though.
Okay, that's it for the pathology part.
So yeah, so diffuse large B-cell lymphoma of the spinal cord. And let's just assuming that this is what it ultimately ends up and ultimately was non-Hodgkin lymphoma. Me, age 67, more common in male. So this gentleman's kind of in that. Immunosuppression is a risk factor, and 1 to 2% of primary CNS lymphomas present in the spinal cord. So something to keep in mind. The CD19 2022 positivities, PAX5 positivity, something to be aware of as in terms of the pathological markers, pathology markers. You can see kind of just normal things that the normal pathological characterizations that Dr. Goltek had discussed as well. Treatment, you can see here. I have to read it for you per se, but biopsy prior to steroids, right? So then in any sort of these lymphatic tumors, lymphomas, or etc. Of the CNS, giving steroids will cause your diagnostic yield of a biopsy to decrease, right? But these are the treatments for it, and unfortunately, median survival is still pretty poor, particularly in the central nervous system lymphomas. And that is all I have.
Good morning. Thank you for inviting me to Random House this morning. My name is Jay Lee. I'm on the 4th floor on Louis Pope. And I'm going to tell you a little bit about some of the ongoing projects in my lab regarding studying the contribution of these lipid-filled foamy macrophages after spinal cord injury and some of the drug discovery approaches that we're taking. I'll start off by saying that we're really not a drug discovery lab. Other people in the building have been holding my hands through this process, and I'll acknowledge them certainly as I show the data. First, I'm going to acknowledge the people actually that did the work. So some of this is, a lot of this actually is from, let me turn my pointer, is from a recent graduate student who just graduated from the PhD program, is now in medical school, Christine Ryan. And second half of the talk was started by a postdoc, former postdoc, Susanna Soqueira, and then more recently taken over by an assistant scientist in the lab, Seth Farrer. I'd like to acknowledge the collaborators who are really important in finishing this work, especially Hassan Ali, who is someone that's holding my hands right now. And then some of the foreign work was contributed by Dr. Sean Bixby and Vance Lemon. And then Dr. Carlos Moraes was really helpful in some of the mitochondria analysis that went into a recent paper that I won't be showing today. Some of the earlier work on macrophage transcriptomics, I received help from the former Miami Project investigator, John Buffet, as well as a collaborator at Drexel, Kara Spiller. Okay, so this is just a diagram of a sagittal section of a spinal cord, just to kind of describe you the biology that we study in the lab. My lab is interested in studying the wound healing process, to be more specific, the immune and glial response to spinal cord injury. And so the wound healing response is typically characterized as by inflammation initially. And so we have this initial damage that causes tissue necrosis and other types of cell death. We have infiltration of immune cells. So a cell population or the cytoarchitecture that was heterogeneous to begin with has now become even more heterogeneous. And this is followed by the phase of cell proliferation. And in rodents, this is typically a peak around 3 days after injury. This is a peak of proliferation for most cells. And then after a couple of days of proliferation, it kind of stops or subsides significantly. And so that leads to kind of cell replacement, mostly obviously of glial and immune cells. Obviously the neurons and axons don't regenerate. And then this is followed by a long process of tissue remodeling, where you have deposition of extracellular matrix molecules. And this kind of leads to what we typically call scar. And so there are actually two types of scars that form. This is the outside, the outside cells here that surround the central region is typically called glial scar. And what's really interesting about this process is that the neural cells and non-neural cells kind of separate out and form very distinct regions. And the central region here is what we typically call the fibrotic scar. And so these are the non-neural cells that invade. Typically, the types of cells that are in here are monocyte-derived macrophages and fibroblasts. And then surrounding that, kind of protecting them from infiltrating and going all over the tissue, are the glial cells that have typically been given a bad rap in that they're thought to prevent regeneration, but they play an important role in limiting the spread of the infiltrating immune and fibroblasts to the surrounding tissue. The one pathology that we've been very interested in are the macrophages and the accumulation of lipids in these cells. So we know from decades of research that monocyte-derived macrophages, which are really distinct from the tissue-resident microglia, that these monocyte-derived macrophages orchestrate a lot of this process. They're certainly important for the development of fibrosis, as they are in fibrosis of peripheral organs, and they also mediate the astroglial response as well. And this is kind of one of the pathologies that was actually first described, one of the few pathologies that was first described in human tissue. And so this is tissue from the tissue bank at the Maimie Project. There have been few papers published with those. The first one here by first author Dr. Michael Nornberg described these lipid-filled, kind of vacuole-filled macrophages, as you can see from the arrows. And then on the left is a follow-up study where they stained with immunohistochemistry. And you can see that there are these empty vacuoles here that are supposed to be filled with lipids. And so we became interested in this for several reasons. And so we modeled this in the mouse spinal cord. And so the mouse model is kind of what we typically use in the lab. And so this is on top here is a sagittal section of the mouse spinal cord after a mid-thoracic contusive injury. In green is immunostaining for CD11B, which stains for myeloid cells. And then in red is staining for oil red O, which stains for neutral lipids. Typically, I think in clinical cases, the oil red O is shown in bright field. But what's really nice about oil red O is that it's also endogenously fluorescent. And so and it's fluorescent in both the red and far red channels. And so we took advantage of this fluorescent properties and did fluorescent immunohistochemistry. And so at 3 days after injury, if you zoom in on this injury site, you see a whole bunch of myeloid cells, these round CD11B positive cells over here. And you can start to see accumulation of neutral lipids, little red dots here. But by 7 days, when this is considered the peak of macrophage infiltration in terms of just the pure numbers of cells, you can see that by this time that almost all of these cells are now just completely filled with neutral lipids, denoted in these red or red of staining here. And so we took advantage of mouse genetics and some novel tools that were present at that time. And so this is a paper that was published in 2017, where we did macrophage-specific transcriptomics. And this was the first one to be done at the spinal cord injury site. And what we did was we took the differentially expressed genes between 3 and 7 days. And then we performed what's called a single set gene set enrichment analysis, where we compared the differentially expressed genes of these macrophages present at the mouse spinal cord to about 19 other publicly available macrophage data sets. We just wanted to know, kind of, because there was a lot of kind of mixed data out there about how macrophages are categorized and considered. Are they M1-like or M2-like, pro-inflammatory or pro-regenerative? We just took an unbiased approach and took about 19 publicly available data sets, mostly in vitro, but some in vivo. And we just wanted to see what these cells were most similar to. And on the top of that list was a data set that was taken from a foam cell study, foamy macrophage study. And so that gave more credence to the idea that these are best characterized as what we typically call foamy macrophages. This is obviously a term that's familiar to clinicians, but for neuroscientists, it's really something that really isn't in our daily vocabulary when we talk about neuropathology. And so this is when Christine started in the lab, and with the help of Hassan Al-Ali, she developed a novel in vitro assay where we can start to test the mechanism of foamy macrophage and lipid accumulation in these foamy macrophages. What's nice about studying macrophages is that we can take the cells from adult animals instead of taking them from postnatal pups that we normally do with neuronal or glial cultures. And the kind of what was typically done before was that people would take cultures of the macrophages and then incubate them with purified myelin. But there's some kind of disadvantages to that approach in that we thought that myelin was just one of the lipid sources. Obviously, all cells are comprised of lipids, and so what we did was we just homogenized the tissue, the spinal cord, and we incubate them, incubate the macrophages overnight. What this allows is to give the macrophages the kind of the more physiologically relevant cues for stimulation. So instead of stimulating with things like LPS and IL-1 alpha and TNF, that's a bit more artificial. We just let all of the pro-inflammatory cues from the spinal cord homogenate do their work. And then in the process, they become inflammatory, very phagocytic, and take up a lot of these lipids. So you can see from the bottom images here. And so these are images now taken with a high content screening platform called Opera Phoenix that we have in our imaging core on the 4th floor. You can see from the images here. So if you just do a concentration, now you just increase the concentration of the spinal cord homogenate, you can see in green, these are accumulated. This is now neutral lipids stained with a stain called Nile red, which also fluoresces. And then the bottom here, the red is a cell mask. It just outlines the cell. And so you can see a nice concentration dependent increase quantified on this graph over here. And so the robustness of this assay allowed it to be amenable for high content screening studies, which I'll get into a little bit later in the talk. And so one of the first things that Christine did was she purified the proteins from these cells and looked at cytokine profile. So this is kind of it's a commercially available ELISA where it tests for the expression of about 111 different cytokines, including housekeeping proteins. And so you can see that this is a media treated condition, and the bottom is a spinal cord homogenate treated condition. You can see that there's certain things that just kind of light up, certain cytokines that light up after homogenate treatment. And so you quantify that, and then you kind of rank it in a list here, starting with the most highly differentially expressed to less differentially expressed ones on the bottom. Shown are all the ones that were statistically significant in terms of being increased or decreased. Interestingly, NCSF was really the only cytokine that decreased in expression, but there were a whole bunch of others that increased. And so what we did here was we took a bioinformatics approach and we did a KEGG pathway analysis based on these differentially expressed proteins to look at kind of do an unbiased analysis of what signaling pathways were associated with the cytokine expression profile. And so we did that here. And then on the bottom highlighted here kind of were the signaling pathways that came up. So there was a HRACE pathway, a JAK-STAT pathway, as well as PI3 kinase and AKT pathways that came up as potential signaling pathways responsible for these cytokine expression. Obviously, this is just computational, and so we took an experimental approach to try to validate this. So we took inhibitors for each of these three pathways. So this is the FPS compound here is inhibitor of the HRACE pathway. We took taurine-2 as the inhibitor of PI3 kinase AKT pathway, and we took static as a JAK-STAT3 pathway inhibitor. Now, initially, and so as you can see from the bar graph down here, right? So this is under vehicle condition, which kind of what's used for normalization for the other conditions. For each compound, we took two different concentration, 1 micromolar and 10 micromolar. As you can see, the only compound that was successful in reducing lipid content in these macrophages was taurine-2. And so at the time, we thought that because PI3 kinase AKT is typically associated with mTOR, there are a whole bunch of inhibitors we could have selected. We chose taurine-2 because we thought that this is kind of a commonly used mTOR inhibitor. So we selected it for that reason, but kind of as you'll see in the later slides, it was kind of a serendipitous selection. So because we thought it was mTOR, we took another mTOR inhibitor that's commonly used, which is rapamycin, and so mTOR, so taurine-2 and rapamycin bind to different binding sites on mTOR, and interestingly, mTORC1 did not actually decrease lipid content in foamy macrophages. And so this was kind of not what we expected, but in retrospect, it was a very fortuitous finding, because now it gave us two really nice tools to study the mechanism of lipid accumulation. We have a compound, so now these two are considered kind of our tool compounds in the lab that we use for a lot of our assays. We have taurine-2, which targets this PI3 kinase AKT pathway and significantly reduces lipid content. But we have rapamycin that targets mTORC1, and that does not reduce lipid content. Well, then, if mTORC1 is not the target of taurine-2, then what are the targets, right? And so taurine-2 is kind of although it's used as an mTOR inhibitor, if you look at the kinase inhibition profile, some of the top kinase targets are actually not mTOR, but rather things like PI3 kinase and some other kinases. So we looked at the kinase inhibition profile with the help of Hassan, and we took a pharmacological approach, and we took inhibitors for all these top compounds. And what we found was that compounds that are highly specific for PI3 kinase do indeed significantly reduce lipid content, as you can see from the image here. So these are two different types of PI3 kinase inhibitor. We tested at different multiple concentrations. And so as you can see, this is a vehicle condition where you have accumulation of lipids. We have similar amount of lipid accumulation when we treat it with one micromolar concentration. But at 10 micromolars, there's a significant decrease, and that's quantified in the graph down below. And so that kind of gave us our first kind of a foot in the door as far as trying to get at the mechanism of foamy macrophage formation after spinal cord injury. But obviously, lipid accumulation itself is not a bad thing, right? So what we believe this leads to is a lipid dysmetabolism in the cell that leads to a pro-inflammatory state. And so I'm not showing a lot of the mitochondrial data here, but it leads to mitochondrial dysfunction that leads to, or that is associated with reactive oxygen species production. So here we have in phase contrast image the macrophages in our culture. We use Manosox dye to look at reactive oxygen species production. And so this is under basal conditions when we just treat the macrophages with media and the vehicle. This is a positive control where we treat the cells with hydrogen peroxide. And as you can see, they light up with Manosox, indicating, as expected, that they're producing a lot of reactive oxygen species. And so now when we incubate the macrophages with a spinal cord homogenate, you can see that even in phase contrast, you can see that the morphology of the cell is very distinct. You have accumulation of lipid droplets that are giving this phase signal here, phase contrast signal here. And then you can see that there's an increase in these red dots compared to the media vehicle group. And then when you treat these cells with taurine-2, there is a significant reduction in mitosoc signal. So that's quantified over here on the graph here. Under media conditions, if you treat with the vehicle or if you treat with TORIN-2, there's not much change in reactive oxygen species production. Interestingly and importantly, if you treat with hydrogen peroxide, there's this increase in reactive oxygen species production. But when you treat with TORIN-2, the reactive oxygen species level is not significantly affected, indicating that TORIN-2 is not just indiscriminately reducing inflammation, but that this seems to be somewhat specific to an inflammatory state that is associated with foamy macrophages. So when you treat it with homogenate now, the decrease in lipid content that I showed you in the previous slide is now associated with a significant decrease in reactive oxygen species production. Not only reactive oxygen species production, but also decrease in pro-inflammatory cytokines. So this is just qPCR from these cells. So this is now 2 concentration of TORIN-2. This is vehicle on the left. So with the vehicle treatment, if you treat the cells with spinal homogenate, you see a significant increase in IL-1 alpha, which is significantly attenuated with TORIN-2. Similar results with CCL6 as well as CCL2. And so with now this TORIN-2 in hand, we wanted to go in vivo and see if we can see these effects in the spinal cord itself after spinal cord injury. So an approach that we took was that instead of just giving TORIN-2 systemically, we packaged them into liposomes. And so using liposomes, so these are liposomes that are about 200 nanometers in size. These liposomes have been used for decades in the immunology field to target macrophages. And so so liposomes filled with cladribine is a tool that's been used in immunology to deplete the body of macrophages. And you just inject them systemically, IP, and then the liver and spleen will take it up. And because most monocytes monocyte-derived macrophages at injury site, not just spinal cord injury, but most tissue injury are derived from spleen initially, this acts kind of as a Trojan horse for delivering compounds to monocyte-derived macrophages at the injury site. And so what we did was instead of using cladribine liposomes, we packaged TORIN-2 into these liposomes and injected it systemically. And so on top here are images from PBS liposomes. So these are, again, CD11B positive cells in green. And then in red is this old red O signal. And then on the bottom row here are animals treated with TORIN-2 liposomes. And as you can see, that in individual cells, there's a significant decrease in old red O signal. That's quantified here on the right. This is the experimental paradigm that we used. So these are, again, about 2 to 3 month old black 6 mice. We do a mid-thoracic contusion, and then at days 1, 3, and 6 after spinal cord injury, we give the liposome injections IP, and then we do tissue extraction at 7 days, and then do histology, and then these are images from those histological assessments, and then these are the quantifications showing that just validating our in vitro studies that treating cells with TORIN-2, macrophages TORIN-2, decrease the lipid content. One of the technical challenges, so obviously then, does this promote behavioral recovery? So one of the technical challenges that we faced here is that, so these liposomes have a limited window into which they can get into the cell, because after a couple of weeks, the blood spinal cord barrier reforms, and we can't get these monocyte TORIN2 treated monocyte into the spinal cord injury site. So after a couple of weeks, if you kind of observe the animals over more chronic periods, the old redo signal comes back. And so this is a drug delivery issue that we are trying to tackle currently. So we're collaborating with other labs to develop novel drug delivery platforms using nanoparticles that can have extended release at the injury site, so that we're not facing this issue. So you can argue, well, why don't you just give it IP? We can certainly do that, but one of the kind of the downsides of using the TORIN2 is that it, in addition to PI3 kinase, inhibits mTOR, and mTOR is really important for promoting axonal plasticity in the central nervous system after spinal cord injury. And so we have this kind of double-edged sword that we have to be careful of. And so initially, we think that it was a great idea to put it so that it's targeting the macrophages specifically. But obviously, we have to come up with other strategies to tackle this long term. And so that's kind of the pathology to describe or to better understand the biology of how TORIN2 or how targeting inhibiting PI3 kinase is working. We took these cells treated with TORIN2, and then we did bulk RNA-seq. One of the nice controls that we had was rapamycin. Because rapamycin and TORIN2 are targeting very similar molecular pathways, we argued that, and since rapamycin does not reduce lipid content in foamy macrophages, so we use that as a control condition. So we had two control conditions. We had the vehicle, all of these conditions are treated with homogenin, and then one condition is treated with just a vehicle. One condition is treated with TORIN2, and then another condition is treated with rapamycin. And then we took the heat map of the differentially expressed genes, and then we did hierarchical clustering on both axes. So hierarchical clustering on this axis now nicely splits the experimental conditions. So you can see that the vehicle-treated conditions group together. You can see that the TORIN treated cells group together, and the rapamycin-treated cells group together. So that was nice that these three conditions were distinct from each other. And then we did clustering on the other axis to look at kind of what gene sets are unique to the TORIN-treated condition. And so we just kept clustering it until we saw a unique signature that popped up in the data set. And so when we clustered it to about 6 different clusters, what we observed was that this cluster number 3, right, had a set of genes that were uniquely upregulated after TORIN2 treatment. And then cluster 4 was had a set of genes that was uniquely downregulated in TORIN2 treated cells. And so we took the list of genes that was upregulated in the TORIN2 treated cells, the cluster 3, and then we did gene ontology analysis for biological processes to look at what biological processes these genes were associated with. And there were a lot of RNA processing terms that came up, but what kind of stuck out to us were terms associated with autophagy. So macroautophagy, regulation of autophagy, and you see some autophagy down here. And so we decided to pursue the possibility that TORIN2 could be promoting autophagy to reduce lipid content in these cells. So Christine did an autophagy assay. So this was kind of a tricky assay to set up in the lab. And what you have to do with these assays to do it properly is to add baflomycin A. And so on the left 2 columns are that baflomycin without baflomycin A, and the right 2 columns is with baflomycin A. And so what adding baflomycin does, it's like if you turn the faucet on in your sink, right, you want to accumulate, you want to see the flow of the water. You want to stop the drain, right? You want to plug the drain. If you don't, then you'll never know really the flow rate, right? So if you want to study the flux of autophagy, you need to add baphyllomycin so that you stop the degradation of the autophagosomes, and so that you can see it accumulate over time. And so if you add homogenate, right, and you add, so without the homogenate, you have a certain level of autophagy. So you can see with adding baphyllomycin A, you can see accumulation of the LC3 puncta, indicating the accumulation of autophagosomes here. And so if you add homogenate, you actually see a decrease. So actually, accumulation of lipids, adding spinal homogenate to the macrophages actually reduces autophagy in these cells. And then if you add taurine-2, you can see that it brings it up back to more basal levels, indicating that addition of taurine-2 promotes autophagy in foamy macrophages. Rapamycin is known to be a autophagy promoting compound, but in the context of foamy macrophages, it doesn't seem to be doing that. And then this is a positive control where we starve the cells to promote autophagy. Okay, so that is one mechanism we think by which the compounds are working here. The taurine-2 is working so that it's promoting autophagy and thereby getting rid of the accumulating lipids that are in the cells. Another possibility that we have to consider and that people always ask is, is taurine-2 treatment just simply preventing phagocytosis of the lipid debris, the myelin debris, and all the lipid debris that's in the cell condition? And to do that, we did a phagocytosis assay. So on top is just regular macrophages that are given these beads that are commonly used in phagocytosis assay. And so normally, if we take regular bone marrow-derived macrophages, and so one of the challenges here is that we couldn't add the beads with the homogenate. For technical reasons, these are technically not foamy macrophages. They're just regular bone marrow-derived macrophages that have been treated with taurine-2. As you can see, if you treat with taurine-2, under normal conditions, it doesn't affect phagocytosis. Cytoskeleton D was added as a positive control to inhibit phagocytosis. And then LPS was added as a positive control to promote phagocytosis. So under basal conditions, taurine-2 doesn't seem to be doing that. But we needed to consider the scenario that our macrophages are in an inflammatory state and thereby have an increased phagocytosis rate. And so what we did was we added LPS to the cells. And adding LPS increases the phagocytic capabilities, as you can see. So there's more accumulation of these beads once you add LPS. And so under the pro-inflammatory conditions, now when we add taurine-2, it actually does seem to decrease the bead accumulation, suggesting that taurine-2 is also limiting accumulation of lipids in macrophages by decreasing phagocytic capabilities of the macrophages. And so this brings into question, well, then is taurine-2 simply working by reducing inflammation and thereby reducing phagocytosis in the cell? Is that kind of the primary mechanism by which taurine-2 is acting on these foamy macrophages? And so because we had this nice condition where we can treat with rapamycin and where it doesn't decrease lipid content, and because we had the RNA sequencing data set from these conditions, we used that data set. We mined our own RNA-seq data set to look at pro-inflammatory cytokines and how they're affected by taurine-2 and rapamycin. And so treating with rapamycin, just like taurine-2, also decreases pro-inflammatory cytokine expression. So you can see that here's a vehicle level. After vehicle treatment, IL-1 alpha expression levels are this high, and then with taurine-2 and rapamycin treatment, it's decreased. It's also decreased. The CCL2 levels are decreased, CCL6 levels, SVP1. And if anything, actually treating with rapamycin increases arginase 1 levels, which is considered an anti-inflammatory marker. And so since rapamycin also decreases pro-inflammatory cytokines, but does not lead to reduced lipid content, we think that it's not likely that taurine-2 is working simply by reducing inflammation. And so the summary so far is that lipid accumulation in fully macrophages associated with increased expression of cytokines and reactive oxygen species, that the accumulation of lipids in these cells is mediated through PI3 signaling pathways, but independent of mTORC1, and that PI3 kinase inhibition by taurine-2 reduces lipid accumulation by autophagy, as well as attenuating phagocytosis. And so to switch gears a little bit, I told you that this is it has turned into now a drug discovery campaign. And so in parallel, while Christine was doing this kind of very hypothesis-driven, kind of a classical approach to studying mechanism, in parallel, we had a study funded by the Department of Defense to do more of a drug discovery project. And so we used these foamy macrophages, and with the help of Hassan, we had a library of kinase inhibitors. So these are kind of manually annotated library of 329 kinase inhibitors that we used to screen, because remember, this assay was robust enough for high content analysis. And so we took advantage of the tools that we had at the Miami project. And so we used the Opera Phoenix for what it was designed to do, which is high content screening. And then we used a machine learning algorithm developed by Hassan, John Bixby, and Vance Lemon, where they used the phenotypic screening to identify kinase targets. And so these are figures from a paper published from their lab when Hassan was a postdoc there. And so what this machine learning algorithm allows you to do is take advantage of the promiscuity of most kinase inhibitors. They use machine learning to kind of deduce what the targets could be based on the compounds that are listed here. And then as you can see, these are hits, meaning that they are promoting the phenotype that you want to see. And then these are non-hits, meaning that they are actually going against the phenotype that you want to see. And then highlighted in yellow here are the inhibition profiles of the specific kinase targets and anti-targets. And so they use this to identify a novel compound that promotes axon growth in the central nervous system. And this compound has now gone into a grant mechanism called Blueprint for Neurotherapeutics that they are working on right now. And so we did the screen. And so this was initially spearheaded by a former postdoc, Susanna, with the help of Brian Kang in the lab. And so these are data points from all the 330 compounds or so that we screened. And so on the bottom here are the different concentrations in log fold. And then this is initially the cell numbers. So we wanted to make sure that we move forward with compounds that were not toxic, obviously. And so you can see immediately that there are certain compounds that are very toxic to the cells. And so we took those out of our analysis, and then we kind of cleaned it up this way. So now these are cell numbers, presumably viability, that indicates viability, the effect of the compounds on the cell viability. And as you can see, there are many compounds that are indeed toxic at this high concentration, 50 micromolars. but most are not so toxic at the lower concentrations. And then we took these to look at the effects on lipid content. And so this is now measuring Nile red intensity. And as you can see, there are immediately some compounds that stand out, right, in reducing lipid content in a concentration dependent manner. Many have no effect. And so if we clean that up, you can see kind of what our hits were. And so these turned out to be about 60 compounds or so that seem to have the profile or the phenotypic outcome that we were looking for, in that it's decreasing lipid content in the cells. And so we fed this. And so this is when Seth, who's currently in the lab, took over the project. And so Seth worked with Hassan in feeding this data set, large data set, into the IDTRACS algorithm. And what was computed from the algorithm were a list of kinases that were predicted to be targets and anti-targets. Target meaning that these are kinases which, if you inhibit, it is predicted to reduce lipid content. And these are the kinases, if you inhibit, are predicted to increase lipid content. And so obviously these are just computations. But what gave us assurance was the fact that PI3 kinase was detected as a target in this computation, in this algorithm. And I just showed you from the first half of this talk that PI3 kinase was indeed a kinase that promotes lipid accumulation in foamy macrophages. That kind of gave us assurance that this approach was headed in the right direction. And so this is kind of a summary slide of our final results from this screening campaign, where these are the targets here, and these are the anti-targets, and then obviously there's some that fall kind of in the middle. And so we wanted to pursue these targets, and because all the tools that we had used were kind of promiscuous so far, we wanted to move forward with the validation of these targets using a more specific kinase inhibitor. So we took very highly specific kinase inhibitors for each of these top 3 hits that we found. Or actually all the hits that we found here. But then these are kind of what came up as ones that had the most significant effect. So inhibitors against PI3 kinase, BTK, and SRC seemed to be the most effective in reducing lipid concentration. So the positive control that we used here is taurine-2, because that was kind of what was identified from the initial study here. And just keep in mind that the PI3 kinase here was kind of discovered in parallel with Christine's study on foamy macrophages. So this was kind of reassuring. So up until this point, taurine-2 had been really our best compound in terms of reducing lipid content. But now we actually have some compounds that are almost as good. And so we have these 3 top kinases now that we've identified. The whole point of this was not to really identify compounds per se, but to identify the kinases that we can use as targets for further drug discovery downstream. And then what Seth was interested in looking at was whether there were synergistic effects between these kinases. And so he did a synergy assay where pretend that this is a 96-well plate, and these are concentrations that are increasing for one inhibitor as going to the right, and then increasing for another inhibitor going to the top, right? And so then on the lower right corner, you have basically the lowest concentration inhibitors for both compounds. And then as you move diagonally across the top, on the upper right-hand corner, you have the highest concentration for both of these inhibitors. And so if these 2 kinases are in fact synergistic, then as you move across the diagonal axis over here, you should see a greater inhibition than either of the inhibitors alone, right? And so we quantify the synergy using this Bliss synergy score. And then this is just a heat map of this score. And as you can see, inhibitors of SRC and PI3 kinase seem to indicate a strong synergistic profile, indicating that these two mechanisms or signaling pathways seem to have synergistic effects in inhibiting lipid accumulation of foamy macrophages. And so as summary, high content analysis using this machine learning IDTRACS algorithm has identified PI3 kinase, SRC, and BTK as targets in reducing lipid accumulation of foamy macrophages in vitro. PI3 kinase and SRC seem to show synergistic effects. And obviously, what we're currently working on is now moving this into into in vivo. We first need to test their toxicity in vivo. And then, as I mentioned before, we are working with another lab in developing macrophage-specific nanoparticles as a drug delivery mechanism. And then, obviously, long-term, we need to test for behavioral and histological improvements. So again, I'd like to thank the people that have contributed to work, and I'll take any questions you may have.
Great talk, Jay. It's Ashish Shah here. I just had a quick question. Have you looked into the prevalence of foamy macrophages in human spinal cord injury patients, like from the peripheral blood, and seeing if they're higher compared to controls?
Right. Yeah. So I showed a slide at the beginning where Dr. Michael Nornberg kind of spearheaded that study. So we probably have the largest collection of human spinal cord injury samples, perhaps even in the world. On the fourth floor, it's just kind of a hidden treasure there. And so that was used to publish a few papers, in the early 2000s, where for sure this is a pathology that's present in humans. And in fact, those were mostly chronic tissues. And so this is a pathology that's present in chronic spinal cord injury site. I don't know of studies that have looked at peripheral blood to see if the blood monocytes are also filled with lipids, but for sure the macrophages at our injury site are filled with lipids. And what we believe that this is contributing to the long-term chronic inflammatory state of the spinal cord.
The reason that's great. I just think that it'd be a great opportunity for one of the residents or something from our group to maybe help and kind of collect specimens so that we can in chronic and acute spinal cord injury see if the lipid accumulation is increasing after the time of injury. These patients stay in the hospital for a week, 2 weeks. We have like serial access to their blood.
I would love to collaborate with anyone who can get human specimens. And so we can do all kinds of transcriptomic analysis, to characterize these cells. There is a large effort spearheaded by I-Court at UBC by David Kwan and colleagues, as well as at UCSF. But certainly, I think we are also kind of in a position to contribute to that work as well.
Awesome. Thank you so much.
Hey, Dr. Lee, this is Jordan, one of the pre-residency fellows. Really amazing work. Just had a question. Are there any mouse models or any, direct inhibitors of the autophagy pathways? Because it sounded like some of the downstream effects were modulating autophagy, affecting how the lipids are accumulating in these foamy macrophages.
Right. So we wanted to test the possibility that taurine-2 was acting through by inhibiting autophagy, and so for sure we think that's one of the contributing factors. That taurine-2 is indeed inhibiting autophagy. We're not really autophagy experts, but we're certainly interested in pursuing lipophagy more specifically. And so if there's anyone here that have experience or are currently studying lipophagy, I'd be very interested in speaking with you. And kind of, something that was that I didn't get a chance to talk about is this lipid accumulation is something that is present in peripheral organs in spinal cord injury patients, right? So they have metabolic disorders that kind of leads them to have fatty liver disease and atherosclerosis, and so we think that some of the compounds that we are pursuing and eventually, hopefully, kind of bring to clinical trials might even affect not just the lipid accumulation of macrophages, but also helping to reduce lipid content in peripheral organs as well.
Yeah, there was a follow-up that I had in terms of, is this like a common pathway in the nervous system and, other organs, atherosclerosis, et cetera, that, if you were to develop compounds that you could see benefits and other diseases in the nervous system or other organs. So yeah, I think it's very amazing work.